to do our panel with our all-star lineup. We're going to ask you guys for questions at the end and give the panelists a chance to speak with you guys. We're also going to do some firsthand accounts, one-on-one accounts about ketamine and how it's helped people on the live here today. First and foremost, we have Dr. Matthew Cook and Barbara Brenneman. They are the founders of BioReset Medical. You've heard Doc and I speak on Delic Radio several times, and you'll hear it in the future. Go check out Delic Radio, of course. And we have Dr. David Feifel, who is the founder of Ketamine Neuropsychiatry Institute. You have also heard Dr. Feifel on Delic Radio. We have the lovely Angela Ward, who is an RN and founder of Guardian at the Gateway. And last but not least, for this round of discussion, we have Julie and Kevin Nicholson, founders of Ketamine Wellness Centers. Thank you to all the panelists for being here today. We're super stoked. All right, so let's talk about quickly the history of ketamine. Ketamine is a dissociative anesthetic with strong cognitive and psychedelic effects. Though popular as a recreational drug, Calvin Stephen first developed ketamine while searching for an alternative to PCP, which produced undesirable effects. With its discovery in 1962, ketamine went through a series of preclinical trials before the FDA approved it in 1970. It became the surgical anesthetic administered to soldiers in Vietnam due to its relative levels of safety in comparison to other anesthetics. Additionally, ketamine has been used on patients with respiratory and circulatory issues and even made its way onto the World Health Organization's list of essential medicines. Recently, the applications of ketamine have extended to treat depression, even suicidal thoughts, because it takes effect much quicker than other antidepressants and produces what we think are more long-lasting results. People are studying that as we speak. And it turns out that today is World Suicide Prevention Day, ladies and gentlemen. Every 40 seconds, somebody prevents, or I would hope prevents, but actually somebody commits suicide around the world. This is a very sobering and true statistic, and I would imagine that it's possibly gone up since I first heard that statistic. It's very real. The different forms of ketamine that we know are IV, intravenous, IM or intramuscular, troche, which are these little guys right here, nasal, of course, nasal spray, and powder form that you would see recreationally. So let's get into it. Let's talk about the nuts and bolts. Why does it work? Dr. Feifel, you have been studying ketamine in your clinic for many, many years. I would love to hear you talk about why ketamine works, or why you have seen it work and how it works.
Thank you, Jackie. It's a pleasure to be here. You know, it's funny because I had this conversation with some colleagues on a chat group, ketamine providers, and some of them were invoking this concept of neurogenesis, which I'm sure a lot of the viewers have heard. Neurogenesis is creation of new brain cells, which at one time, not too long ago, we thought was not possible. We thought that the brain did not actually generate new brain cells after birth, but then neuroscience discovered that in certain areas it did. And ketamine is known to rapidly produce this neurogenesis. And so it's been a very kind of seductive story to describe, to explain ketamine's profound effects, therapeutic effects with this neurogenesis. And I pointed out to the group that unfortunately, the evidence is really not that, it's a nice story, but the evidence is very mixed about whether neurogenesis has any role in it. And I think what my point to them was really that there's a lot of theories. We know that ketamine does a lot of things in the brain, but the truth is, if we're going to be intellectually honest, we don't know. what what the mechanism of action for ketamine is. We do know, for example, some characteristics, like it binds to a certain receptor called the NMDA receptor, that it blocks this receptor. Again, that it has these changes, both physiological and obviously psychological and perceptual. But we're still trying to figure out what is the key component to ketamine, and why the experience that people have with ketamine is very similar. And this has been shown in controlled studies, very similar subjectively to other psychedelics, but yet it has a different pharmacological mechanism, at least initially, to where it binds in the brain. Honestly, I could cite several interesting provocative possibilities, but the truth is we just don't know. And it's a great area if you want to be a researcher.
Yes, I thank you for that answer. It's so honest, so true, and I think healthy. It's okay that we don't know, and we do need more researchers and chemists to study the, ketamine and other psychedelics to that too, because I know you wanted to talk about the S-ketamine and insurance. But before that, we have a couple of questions I'll give to the panel from viewers. A lot of people asked about interactions. What other drugs can ketamine or should ketamine be mixed with or not mixed with? That's a very complicated question. Does anyone on the panel want to take that? Dr. Feifel, we haven't heard from you in a minute. Do you want to answer that?
Sure. The truth is, there's been some evidence that certain drugs may interfere with the ketamine effect, may mitigate it. For example, there's been some evidence that a drug called lamotrigine, which is also goes by the brand name Lamictal, which is a anti-epilepsy drug, but also even more commonly used as a mood stabilizer and sometimes antidepressant, can mitigate the effects of ketamine. But that's, in clinical experience, speaking to a lot of people, and I would say in my own experience, that's not been borne out very well. In fact, and one of the strange things that that a lot of people who cite, it was a small paper reporting on some case reports. But it was interesting about that study was it actually mitigated the experience of the the dissociative experience, the psychedelic experience, but actually did not mitigate, in fact, enhance the antidepressant effect, which is very interesting and unusual, and part of my interest in to what extent is the subjective experience related to the antidepressant effect. It's I think we think it's important, but we don't know exactly. There's some people who feel that taking a benzodiazepine, that would include drugs like Valium and Xanax and Klonopin and Ativan, can interfere with the ketamine effect. And that's also, for none of these things, I should say, is there clear-cut scientific, the jury is out on these. But for example, in that latter case, I have found, and a lot of my colleagues agree, that actually it really depends on the situation, that a benzodiazepine can actually enhance the experience and the therapeutic effect when given in the right time. For example, a patient who is at first treatment extremely anxious about it, and we feel that anxiety is not sufficiently addressed by non-pharmacological. We have a great team that can really work with people to reduce their anxiety, but sometimes it's just so strong that we feel that it would be counterproductive to do the ketamine in that state. And so in those states, we found that pre-treating them with a benzodiazepine actually can turn the experience into a much better one. So I would say there, in summary, I don't want to go through all the the list of things. I would say that there's no drug that is absolutely a no-no to combine with ketamine. There are some things that might have some interaction effects, but in the right circumstances with somebody who's very knowledgeable, they could be fine and even beneficial.
Got it. Wow, that's super interesting. Before we switch over, we got a lot of this question about ketamine in breast milk. What is the effect of ketamine in breast milk or on children who consume it? Anybody on the panel want to take that one?
You know, one of the interesting things about ketamine is that I like pointing out to patients is that whereas if you take most other drugs for depression or other psychiatric things, or even for medical issues, you know, you're taking that drug every day, and if it's benefiting you, it's benefiting you because it's actually in your blood system, and in psychiatric drugs, it's in your brain. What's really interesting about ketamine as sort of a paradigm shift is, if patients get even a week of benefit from ketamine as an antidepressant, during that week, there's no measurable ketamine in their blood, and this obviously has implications for breastfeeding. Ketamine's effects occur kind of like kidney dialysis, where you go in, whatever the interval is, let's say it's once a week, and you get hooked up for an hour, and your blood gets cleared of toxins, and the next day, if you're feeling well, it's not because you're still getting kidney dialysis, it's because of what happened while you were at the infusion center the day before. You're still doing well, and eventually the toxins will build up. So ketamine is in some ways like that, and that makes it different than other drugs vis-a-vis tolerance, for example, because tolerance usually occurs when your brain is exposed to the drug on a continuous basis. It has implications for this question for breastfeeding, because a mother can get a treatment for ketamine and then waste some of the breast milk depending on the timing, and then new generated milk would be perfectly fine because there's no ketamine in her system to be sort of absorbed into the breast milk. So it's very important to keep in mind the different way ketamine does produce its therapeutic effects.
Lovely. Thank you for that explanation. That's very clear. I think, Madison, too, this brings up something I wanted to discuss, and that's about ketamine. Do you need to consume a substance in order to administer it, or prescribe it, or whatever, however you're acting as a doula, whether it's as a doctor or as something else? And I think, what do you guys think? Do you need to know the substance before you can prescribe it?
Well, this is something that I've had a lot of conversations with colleagues who've been doing ketamine for a long time, like me. I should clarify also, doing is a ambiguous term, but treating people with ketamine. There's one of the things I would say, and maybe some people will be upset by this. I'm a scientist, and one of the reasons I think that medicine is great is that contrary to what people think, it actually has no dogma. There are dogmas at certain points of time, but we've seen so many concepts in medicine overturned. And everyone who's gone to medical schools had the experience of first day, a big lecture, and the professor saying, everything we're teaching you now was going to be probably considered inaccurate, incorrect, incomplete. That's part of the amazing process of medicine. And ancient medical systems don't do that. They're a dogma. This is the way it is, and it's because you have chi or energy, and nobody asks the question. So I just would say that I'm very open-minded, and I think it's part of the exciting thing about working with ketamine is how different it is, and how it involves the psychological state and setting, and the patient being a participant. And I explain that to every one of my patients. But there's also, I know there's a lot of dogma that comes from the preclinical use of psychedelics. There was when we started seeing these studies come out of NIMH, another place, where intravenous infusions of ketamine with no therapy were having remarkable effects. I spoke to many colleagues who were therapists and said it's not possible. They've worked with ketamine. Ketamine is just a lubricant for therapy. It doesn't have its own effects. They now, with the overwhelming evidence, acknowledge that probably isn't true, that even by itself, ketamine can have incredible effects, but still will believe that therapy plays an important role. And so so there's a lot of other things. There was beliefs that ketamine cannot have you cannot do it inside a building. You have to be in nature. A lot of these things have been shown not necessarily to be accurate. And so and one of the dogmas is that you have to experience these drugs. And it might be true that that's a positive experience, but nobody's been able to really give me a good explanation for why we have to do that with these drugs, and not, if you're giving cancer drugs, you have to experience the nausea of cancer drugs or so forth. And I had one person say to me, well, if I was, the analogy was, if I was climbing a mountain, I would want the Sherpa to have experience climbing that mountain. My response is, there is no one mountain. Every mountain is going to be different. And if your Sherpa has been up his mountain, thinks that that's what the mountain is, he may actually be a liability, because the mountain you climb with him may be different, and he's assuming that it's his mountain. So psychedelic experiences are different from person to person, and they're different from within a person from time to time. And I could say that, in closing, that I've had, there were times where we've thought about doing support groups with people who've had psychedelic experiences. And part of the reason we stopped doing that is that they had such different experiences. It was frustrating to some of the patients. It's like, why am I not experiencing that? So I'm not saying yes, it's important or not important, but we need to put everything to the test. I think all these things need to be evaluated in good experiments, and we're actually planning an experiment where we're going to be, having, the type of therapy, for example, that some people insist intense therapy, whereas more of just a set and setting approach. And I just encourage us to be open-minded and agnostic going into these things. Now, get off my soapbox now.
No, I love it. Thank you. Beautifully said.